I'd like to begin our first session of the day talking about the impact of the presidential election and politics on worksite health centers. We're going to be privileged to have some great panelists representing employers and the industry and business organizations who have a national stamp on what's going on in the future of this country. We're going to start off by having a presentation by Jim Klein, the CEO of American Benefits Council. If you're not familiar with ABC, it is one leading trade associations in Washington, D.C., representing primarily 500 companies who either sponsor or administer healthcare benefits and retiree benefits for over 100 million lives. Along with Jim, we're going to have panelists who are going to respond to that. Our first one will be Stu Clark, who is the CEO of Premise Health. He's been the CEO since 2014, and he has held roles in other key industry leading organizations like CHS Healthcare and others. As you may know, Premise Health and Care Here recently joined together. And so we're representing, I think, close to 800 centers or close to that. And I think Stu will tell us a little bit more and give us the industry perspective. We'll then have the board chair of NEWHC, Carly Deer, who's senior benefits leaders for Target Corporation, where she leads their benefit strategy for over 350,000 of their associates. And then we'll have James Gelfand. James is a senior vice president of health policy for the ERISA Industry Committee, also known as ERIC. He works with them to develop and advance their public policies to support their efforts for very large employers to design and administer health plans, and focuses on the legislative and regulatory efforts. Both Jim and Stu and Carly and James all support some of the NOWIC activities that we're involved with, and we'll talk a little bit about during the presentation. So at this time, I'm going to share my screen and turn it over to Jim to present. So let me get my screen up here a second. Just bear with me, and we'll be able to get started.
Thanks, Larry.
Yeah.
While you're doing that, let me just make a couple of preliminary comments. I just really want to commend and thank your organization for the work that you do. As Larry indicated, we represent 220 of the nation's largest Fortune 500 companies, and needless to say, many of them host worksite clinics, believe very firmly in the importance of them in terms of promoting good health on the part of their workforce. And the work that you all do just so incredibly helps the work that we do here in Washington on behalf of large employers. And I just commend the organization and all of you as individuals. So Larry and Carly, thank you very, very much.
Thank you, Jim.
I want to jump right into it. A lot of information to cover, and I think Larry's going to be advancing slides for me. So go on ahead, Larry. I'll just give you the cue. Next one.
Okay. Hold on a second.
All right. I wanted to start out a little bit talking about politics and how legislating itself has changed. It used to be, and I guess I've been in the business long enough to remember a time when the moderates in Congress, that is to say the moderate to conservative Democrats, the liberal to moderate Republicans, really held the power. There were enough of them in Congress that the leadership of both parties needed their support in order to get any legislation over the finish line. And their price for agreeing to do it was that the policy needed to be in the middle of the political and legislative spectrum, and it needed to be done on a bipartisan basis. So it was the case that any consequential legislation really could only pass if it was done on a bipartisan basis. And this isn't just true, of course, for healthcare related issues, but for everything. But in our world, Medicare, ERISA, COBRA, HIPAA, all those things were enacted on a bipartisan basis. Well, now, for a variety of reasons that we can talk about when we get to the Q&A, if you like, the moderates are nearly extinct in Congress, as you know, and to the extent that there are so few of them, they have become virtually irrelevant in terms of having any political power. And so the last several years, the only consequential legislation that passes is if it's done on a purely partisan basis, when both houses of Congress and the White House are controlled by the same party. And we saw that with the Affordable Care Act, which of course passed exclusively with Democratic votes. We saw that with the efforts to repeal the ACA, which came ever so close to happening, but for 3 Republican votes in the Senate. Certainly saw that on the tax reform measure, the Tax Cuts and Jobs Act at the end of 2017, that again was only supported by Republicans. So what that means for all of this, apart from sort of further exemplifying the sort of the polarization here in Washington, is that laws are very vulnerable to be repealed when the political winds shift because they weren't enacted with that bipartisan consensus. Next slide. I want to just say a few words about why I think the polls that we're all hearing about are almost meaningless at this point. The presidential race is not truly a national election. It's conducted on a national basis, but as we know, it's really all about who's going to win in the dozen or so swing states that really determine the election. And I think that these 2 numbers here on the screen really underscore that point. Hillary Clinton nationwide in 2016 received 2,865,075 more votes than Donald Trump. But Trump received 79,646 more votes than she did in the 3 states of Pennsylvania, Michigan, and Wisconsin combined. So that means essentially, and those states were enough obviously to give him the Electoral College victory. So another way of looking at it is that 0.06% of the more than 130 million Americans who voted decided the election. So if somebody tells you that, I don't think my vote counts, well, I suppose if they live in a solidly red or blue state, they may have a point. But if they're in the swing state, that's not the case. And in any case, 40 days is an eternity in politics. And so a lot's going to change, particularly when you consider how many millions more people are going to be voting early this year. Next slide. Turning for a moment to the upcoming congressional elections, currently there are 53 Republicans and 47 Democrats in the Senate. But perhaps the more significant point for purposes of the upcoming election is that the Republicans are defending 23 seats and the Democrats only 12. So putting all other issues aside, just from a purely math perspective, the Democrats have about twice as many opportunities as the Republicans do to win votes and sort of flip a seat over to their side, which is just the exact opposite of the way it was in 2018, where actually the Republicans had 3 times as many opportunities. So they start out with the Republicans sort of at a mathematical disadvantage, shall we say. In the House, you see the numbers on the screen in terms of the split between Republicans and Democrats. But what that means is really that just a net swing of 18 seats to the Republicans would actually put them in control of the House of Representatives in the next Congress. Healthcare policy is going to loom large for many reasons. Part of it having to do, obviously, with the forthcoming Supreme Court consideration of the ACA case. I'm going to talk quite a bit about that in a minute. But also, I would just point out that the reason the Democrats grabbed control in the last election was that they managed to flip from Republican to Democrat a number of swing districts. And those more moderate Democrats are running for re-election for the very first time. And they're very, very concerned about the calls from the more progressive wing of the Democratic Party for a Medicare for all type of approach. And so they're doing what they can, to distance themselves from that message, obviously being helped by the fact that Vice President Biden is also not a public advocate of Medicare for all. Next slide. So if we're going to talk about the politics of all of this, I need to just say a few words about the short-term legislative outlook. As I think you know, the House of Representatives passed the pandemic relief legislation, the HEROES Act, back in May. The Senate introduced a bill over the summer and then failed to pass a much narrower version of that measure, the HEALS Act, just about two weeks ago now. Looks like Congress is headed toward passing legislation by the end of this month to keep the federal government operating when the new fiscal year begins on October 1st. The House has passed its measure and looks like the Senate will soon. Um, to those who may tell you that, oh, well, a lot of these issues may get dealt with in the lame duck session, I would say don't count on that at all. The lame duck session is likely to be tied up with disputes over the outcome of the election, both congressional as well as presidential. If the Supreme Court nomination is not decided before November 3rd, it will certainly be considered after that. And Congress will have to extend government funding again, since the measure that's likely to pass is going to expire on December the 11th. So sometimes those government funding measures prove to be a vehicle for other issues like our employee benefit matters, but hard to imagine a scenario in terms of the outcome of this coming election that would put either party in the mood for cooperating on any substantive legislation, or for that matter, seeing it in their political interest to do so, given the current split in Congress. Next slide. Next slide. So I wanted to say a very few words about some of the healthcare priorities that might have been considered during this Congress, but got sidelined by the pandemic. And frankly, by the end of today, we'll have more news around much of this, because the White House is going to be issuing 4 executive orders later today, one having to do with surprise billing, another one on mental health, another one regarding pre-existing conditions, and a 4th one likely on abortion issues. That might change a little bit, but that's the expectation. Surprise billing was one of those issues for most of this Congress that had a good deal of bipartisan support. The hang-up really was not between Republicans and Democrats so much as it was between the Senate and the House. The Senate clearly was in favor of something that's more in alignment with what we in the employer community have been advocating, and James may want to comment on that a little bit later, because our organization and his organization have been working quite collaboratively around this issue. But to really say that out-of-network providers should get reimbursed at a median in-network rate. House of Representatives has taken a position much more aligned with healthcare providers in saying that all but the lowest of disputes from a dollar perspective should be resolved through mandatory dispute resolution. The administration has made rumblings that it wants to support just a straight ban on surprise billing, but not necessarily specify what the appropriate reimbursement should be. We'll see what they say about that this afternoon in the executive order. There was a lot of progress, at least over in the Senate, on price and quality transparency issues, removing gag clauses to give employers access to their own data, prohibited anti-competitive contract terms imposed by hospitals, and so forth. Drug prices is another issue that both parties were interested in. They probably wouldn't have come to agreement on that this year. The House of Representatives passed a sweeping measure last December that, among other things, would direct the Centers for Medicare and Medicaid Services to negotiate directly with drug manufacturers. The Senate bill did not do that, but both bills would provide for rebates to the Medicare program if prices exceeded a certain measure of inflation. And then on the ever controversial issue relating around PBMs, that Senate lower healthcare cost measure that deals with price and quality transparency and the surprise billing issue also includes the provisions that would require rebates and discounts to go to the plan sponsor, which is contrary to what the administration had been pushing for. You may remember they started a rulemaking back in 2019 that would have required those rebates to go to the consumer at the point of sale, but the actuary for the CMS, as well as outside independent actuaries, determined that doing so would increase premiums, because obviously Medicare program uses those rebates to help mitigate the amount that participants charge. So they held up on that rulemaking, but now, pursuant to an executive order some months ago, they're supposed to move forward on that if they can figure out a way of allowing for those pass-throughs without increasing premiums on participants. Next slide. Very briefly on COBRA, and there will be a Democratic Senate bill introduced later today, as a matter of fact, multi-stakeholder effort to try to keep people on their plans. Congress has subsidized COBRA twice in the past. They did so just at a 65% level As a result of that, only about 1/3 of those eligible for COBRA did actually enroll in the past because it still was out of reach for people who were unemployed. I include this in here not because the prospects for COBRA subsidies is necessarily looking all that positive, although 100% subsidies were included in the House-passed HEROES Act, but because it has engendered criticism from both the political left and the right. From the left-hand side, they've not been too enthusiastic about COBRA subsidies because they say that the current situation has sort of underscored the problem of linking healthcare coverage with the employment relationship, and that's why Medicare for All is needed. On the right, there's been some criticism to say, well, instead of COBRA subsidies, why don't we just have those people go into the exchanges where they'll be eligible for premium tax credits? Anyway, hope springs eternal. There still are millions of people who need this coverage, and so we and the coalition we put together, the Alliance to Fight for Healthcare, are still pushing as hard as we can to get these COBRA subsidies included in any kind of pandemic relief legislation that might make it over the finish line this year. Next. Sorry, I'm racing through some of this pretty quickly, but I want to be sure to get back to the political stuff. On worksite clinics, I don't need to tell you all how the pandemic has underscored the value of these clinics for purposes of helping, among other things, promote social distancing. The introduced version of the HEALS Act, that is to say the more robust Senate pandemic relief legislation response, would have codified and expanded upon the IRS guidance from 2008 that sets forth certain qualified items and services for purposes of HSAs, and you can see them here on the screen. Next slide. That measure, should it be enacted, would expire at the end of 2021. So our efforts are certainly aimed at trying to make sure that a provision along those lines would be included if there is another round of pandemic relief legislation, and frankly, beyond that, to see if we could make those changes permanent. You also are probably familiar with the guidance that came out recently from Health and Human Services, Department of Labor, and Treasury that confirmed that offering benefits for diagnosing and testing for COVID at a worksite clinic does not undermine the accepted benefit status of the clinic. Next slide. All right, so back to the impact of the election. Since the title that was given to this presentation was not just the election, but impact of politics, I feel it's well within the jurisdiction here to spend some time talking about this upcoming case that the Supreme Court will hear now for the third time, questioning the constitutionality of the Affordable Care Act. So just by way of history, because it's pretty important, the Tax Cuts and Jobs Act would have reduced the individual mandate penalty to $0, did reduce it to $0. Whereupon, shortly thereafter, in early 2018, Texas and 19 other states sued the federal government, asserting that the ACA was unconstitutional in the absence of an effective individual mandate penalty. The Justice Department, which generally defends the United States when it's being sued, generally agreed with the plaintiffs in this case, the Republican attorneys general who brought this suit, but they did argue that with the zeroing out of the penalty for the individual mandate, that the market reforms should be invalidated, specifically the protections for those with pre-existing conditions should be invalidated, which is a kind of, from a legal perspective, there's some rationale to it. From a political perspective, it's quite unusual, in as much as the one thing that the Republicans have consistently said they like about the ACA are the protections for pre-existing conditions. And of course, this executive order that's coming out later today is undoubtedly going to reinforce that point. But such is the nature of litigation sometimes. The trial court, the district court, struck down the entire Affordable Care Act. It said the fact that the individual mandate penalty was not raising any revenue meant it was no longer really a tax, and therefore the rest of the law had to fail. At this point, the federal government, Justice Department decided it wasn't going to defend this case anymore. California, some Democratic attorneys general, led by California and joined by about 20 other states, appealed that decision to the Court of Appeals. Next slide. Court of Appeals almost a year ago agreed that the mandate is constitutional. I'm sorry, that the individual mandate is unconstitutional because it is still on the books. It's just a zero penalty. For technical reasons, they couldn't repeal it altogether. They could only zero out the penalty. But they said that the district court had was too broad in its opinion, that there was not a justification made for why the entire law should be thrown out. So they sent it back to the trial court to determine which provisions of the ACA no longer are valid. At that point, Democrats, led by California, made what now has turned out with Justice Ginsburg's untimely passing to have been a tactical mistake. Rather than allowing the case to go back to the trial court, they sought expedited review by the US Supreme Court. And they did so for two reasons. Number one, they knew that Justice Ginsburg wasn't going to be on the court, forever, and they wanted the Supreme Court to hear the case while she still was there, because of course back in 2014, the Supreme Court upheld the constitutionality of the individual mandate. And they also, I think, wanted this to be a more prominent 2020 election year issue. The Supreme Court declined to get involved in the politics of the election, so they declined to hear the case on expedited review, but they said, we'll hear it next term. And of course, then they scheduled the oral argument for literally 1 week following the election on November 10th. Chief Justice Roberts and 4 other justices, including Justice Ginsburg, back in 2014, found the individual mandate constitutional back then. The 2 new justices who have joined the court since then replaced justices who had voted against the ACA's constitutionality. So the fact that they've joined the court doesn't really likely change the outcome. But obviously, with Justice Ginsburg's passing, a supporter in that 5-4 split is no longer there. There are multiple scenarios to what might happen, and I just want to have one more slide here on this case. A lot of what I'm about to say may not be relevant if a new justice is confirmed before Election Day, which is looking increasingly likely. But if a new justice is not confirmed, the court could do a number of things. They might decide to reschedule the oral arguments, feeling that this is such an important case, it should wait until there's a full complement of 9 justices. But if Chief Justice Roberts wants to uphold the law, and he wrote the decision back in 2014, he may want to do exactly the opposite. He may want to proceed quickly and have the court hear the case on November 10th and very quickly even issue an opinion, perhaps before a new justice is even confirmed, because although she won't have been on the court when the case was heard, she still could vote on the case if she so chose. It's sort of a custom that they don't vote on a case if they hadn't been there and heard the case, but that's not a requirement. So if the court splits again 4-4, as it would seem it would be likely to do so, it would uphold the appeals court decision, finding that the individual mandate is unconstitutional. So you might wonder, well, why would Chief Justice Roberts want to do that? Well, I think the reason might be that it would then send the court back to the district court, as would have otherwise likely happened, and it wouldn't come back up to the Supreme Court for another couple of years by the time it winds its way through the judicial process. And so much could change, both with respect to the court and with respect to what Congress might do in that intervening time. The court could also find that the mandate is constitutional, because on the theory that it still is there on the books and a future Congress could actually raise the penalty. So they might actually surprise folks around that. If the law is upheld, depending on the election outcome, then the Democrats, should they prevail, will move forward to try to strengthen the ACA. But I will tell you this, that if the law is struck down, even if Vice President Biden wins and the Democrats control both houses of Congress, don't look for them to reenact the Affordable Care Act. Their argument is going to be, been there, done that, what good did it do us? The law got undone. We need to do something different and something with a bigger governmental footprint. Larry, tell me how many more minutes I have so I don't cut into the time for anybody else.
You're fine. You've probably got another 10 minutes.
Okay, great. So quickly here, just on a big sort of high level points, how might a Biden administration and a second Trump administration differ on some of the key issues? Well, on healthcare coverage, Vice President Biden, opposes Medicare for all, Senator Harris during the election, primaries supported it, but he's at the top of the ticket. He's talking about retaining and strengthening the Affordable Care Act, increasing the number of people eligible for premium subsidies on the exchanges, and in fact increasing the subsidy amounts. There's a little bit of concern there in terms of some of the proposals that the campaign seems to be talking about relative to requiring the employer mandate to apply even if an employer has offered minimal essential coverage, which would really turn upside down on its head the whole notion of how the employer mandate and the penalty is supposed to operate. Biden does support creating a public option, which, as you remember, was something that Congress considered back in 2010, but rejected, and would allow for Medicare enrollment starting at age 60. The current administration, of course, opposes Medicare for all, supports repealing the ACA, opposes a public option, supported the expansion of plans that are not subject to the ACA, such as short-term duration plans. There actually may be something about short-term limited duration plans in the executive orders that will come out later today. And very importantly, finalize the rule that would allow not just small employers with 50 or fewer employees, but any employer of any size to put money into a health reimbursement account for their employees, meet their ACA obligations, and have those individuals go out into the individual exchanges to purchase coverage. A real movement, if this takes hold, toward a defined contribution approach to plan sponsorship. So to the extent that that rule holds and the ACA is still in effect, that could over time make some fairly dramatic changes to the nature of how employer sponsorship of healthcare is provided, at least insofar as, say, mid-sized companies are concerned. Go ahead, next slide. On healthcare costs, obviously, there's always overlap between costs and coverage. Biden has talked about using antitrust laws to prevent anti-competitive consolidation within the healthcare provider community, to negotiate prices under the public option that he advocates, and support a prohibition on surprise medical bills. Trump has previously issued regulations increasing price transparency for hospitals, employer-sponsored plans, insurers, expanded the ability again to use those lower cost plans like those short-term limited duration plans and association health plans where groups of smaller employers can gather together and establish sort of a multiple employer type of arrangement. Those types of plans can offer fewer benefits, but he also, of course, as I indicated earlier, supports a prohibition on surprise medical bills. Next slide. There we go. Drug prices, always a big issue. As I indicated, after the 2018 election, the number one issue in all the polls in 2018 among the public was healthcare. The number one issue within healthcare was not coverage or quality, it was cost. And the number one issue within cost was drug prices, which is undoubtedly why the Democrats passed the big sweeping measure that they did last year. They will return, whoever's in power next year, to this issue. If Biden wins, he wants to enable the federal government to negotiate directly with the Medicare, for the Medicare program to negotiate directly with the pharmaceutical companies on drug prices, and for certain drugs under Medicare to impose certain inflation limits and limits on the launch price of a new drug, and would also allow importation of drugs from other countries. Current administration, they're reelected. They oppose government negotiation. He did sign a law banning gag clauses on pharmacists to advise customers on lower priced generic alternatives. Proposed, but as I said earlier, not yet implemented, this rulemaking around pass-through of rebates and discounts from PBMs to the consumer at the point of sale. Obviously, the issue there is, for those who are large consumers of pharmaceuticals, that pass-through to the point of sale is very beneficial. For others who are part of the plan, it needs higher premiums. And there is legislation to try to apply that same pass-through to the point of sale to the commercial market as well. What the rulemaking is dealing with is just related to the Medicare program. And next slide, please. With respect to COVID-19 response, Vice President Biden supports expanded testing, of course. There should be no costs to the individuals for COVID treatment, rather than posing that on the health plans. However, that would be supported, he proposes, through greater government funding, and to reopen the ACA special enrollment period for the uninsured, something that may be, of less and less importance as time goes on. By the time he would be in office, of course, will have been a new open enrollment season already. Trump, he did sign a series of COVID relief bills earlier this year. And as we know, he has largely delegated responsibility to the states and has stated opposition to reopening the ACA enrollment period. And next slide. So just to wrap up here, I wanted to conclude with the following couple of thoughts. Whoever wins, whoever controls Congress, whoever controls the White House, the issue of the tax expenditure related to employer-sponsored healthcare always looms large. This chart shows us how and why the tax favor treatment of employer-sponsored healthcare coverage is considered by the federal government to be the largest tax expenditure in the entire federal budget. A tax expenditure being any provision of the Internal Revenue Code that accounts for lost revenue to the federal government. So as you can see here on this chart, the amount of lost revenue related to tax favor treatment of retirement plans, of home mortgage deduction, of charitable contributions, those are all tax expenditures. The federal government estimates that $3.1 trillion, with a T, trillion dollars of taxes would be foregone over the next 10 years as a result of the fact that we all who are fortunate to receive employer-sponsored healthcare coverage do so on a tax-free basis. There are a lot of flaws with the underlying assumptions here, which we can talk about further if you like, but that's the number that federal government uses. And it's the reason why the tax treatment of employer-sponsored coverage is always so vulnerable and is always so much on the table. And certainly if a Biden administration, for example, moves forward on a measure that's going to increase taxes, which he has promised to do, the largest expenditure is likely to be, pretty exposed. So next slide, my last slide actually. So we said, you know what, we don't agree with the underlying assumptions that say that the federal government really loses $3.1 trillion, but let's assume the federal government is right. So what are we as a nation getting for this enormous expenditure? Because it is a large expenditure, there's no question about that. And looking at the most recent data that was available, found that in 2016, because you needed to go back that year to make the appropriate comparison, employers spent $691 billion on group health insurance, but the revenue loss to the federal government was just, quote unquote, just $155 billion. So in other words, for every dollar of tax expenditure, foregone tax revenue to the federal government, employers were spending $4.45 on healthcare coverage for their employees and their family members. That's an incredible bargain to all of us as taxpayers, to the federal government. It would cost us as taxpayers so much more to provide that same level of financial protection if it had to be done directly through an expanded government program, for example. So I think whoever wins, we're going to have just an honest discussion about the pros and cons of the individual system, the employer-based coverage system, and the government system. Adjustments may be made in terms of the relevant role of each of those three pillars of the healthcare coverage system. But I think it needs to be an honest and straightforward conversation about what's good and what's not as good about the different approaches. With that, let me stop, and more information available there. Turn it back to you, Larry.
Great, thank you very much. Appreciate, Jim. It was always good to hear from you, and you always provide us some real insightful information. All right, now I'd like to turn it over to our panelists, Stu Clark, CEO Premise Health. Stu, hopefully we can hear you now. And let's say hello to the audience here.
Hi, Larry. Are you able to hear me at
Yeah,
this point?
that's fine. So give us your perspective on this from both premise health interest as well as your view of the industry.
Thank you. And Jim, I thought that was a great overview. So thank you for some deep insight. Look, I want to lower expectations here. I certainly don't have a crystal ball. I think Jim shared some very interesting vectors that could be at play. You know, my view, and I recognize that I'm biased like my peers that sit in my role across the industry. You know, when you have a hammer, everything's a nail. So of course, employer-sponsored primary care centers have a bright future regardless of the legislation is where we would come out. But let me maybe add some color to our conviction around that. There are going to be a substantial, there will be fewer primary care providers on the other side of COVID. The independent primary care docs are going out of business or they're quitting and going to work for the hospital system. COVID crushed them from a revenue and process and ability to continue to practice standpoint. So now more than ever, our centers, our industry is very, very important to the ultimate payers, the employers. And I think our industry's done a great job articulating that value proposition throughout the spring and summer. The other thing I'd say is that, you know, having been in the industry like so many of us for decades, you know, since the early 90s, we were scared of HMOs. We were scared of, you know, more aggressive managed care approaches. You know, we were scared of ACOs. We were scared of the ACA. You know, I tend to simplify this and along the following lines. The American public continues to behave badly as it relates to their health, their lack of movement, their poor diet, their high calorie diet. You look at the rate of diabetes and hypertension and comorbid conditions, it's getting much, much worse at an accelerated rate. We can legislate and cost shift and tax or not tax, doesn't matter. At the end of the day, the employer, and I think Jim made a really good point about the employer's financial importance to this conversation. The employer is going to take care of their own because they feel like they'll do it better than anybody else. And so I'm highly confident that our industry, regardless of where this legislation ends up and who wins the White House or Congress, I'm confident that the golden age of direct primary care, employer-sponsored health centers is upon us. Let's just take an extreme example. Let's say that we have government-provided nationalized health care. Let's just say it goes there. And I don't think there's any chance of that, but let's just say it does. What happens then? I would argue that we would evolve into a private system just like every other nationalized system in the world. So I believe that a private employer network would spring up on top of and separate from a government-sponsored plan. That's what we hear from our customers. It's logical. It makes economic sense. How you work out the credits and the tax for that, you know, I think Congress would have to listen to large employers and public employers because they are paying the bills. So thanks, Larry.
Great. Thank you very much, Stu, for your perspective. Carly, Head of Benefits for Target Corporation, give us your views from your company's view and what you think other employers are thinking.
I also just want to compliment Jim on that amazing overview. I think it hit all the high points and it was very succinct, and so I appreciate that time. There's so many different things that are going on in my head right now after that presentation and Stu's comments. I completely agree that, you know, worksite health is not going away, and I feel as we're navigating through COVID right now, that importance of a trusted partnership with the trusted provider group to ensure that our employees are, you know, getting their primary care, that they are getting their flu vaccine, that they are not neglecting their health is really important. And to have a strong partner there to make sure that we're continuing to meet the needs of our employees through COVID is very important. I think, you know, as we navigate what potential vaccinations and that whole implementation process could look like, having that strong partner with a near-site or on-site clinic is going to be key to making sure that we can actively engage and get those vaccines out to our team member population. I think the other thing that's just looming, and we're really focusing on from a target perspective, is how is the trauma from the pandemic? How is the trauma from the social unrest? How is the trauma from the results of the election? How is that all impacting our employee population? And how can our on-site clinics help our team members process and deal with that trauma? So making sure that they're keeping an eye out for how patients are presenting at the clinic, right? It could be a physical symptom, but really that's manifesting from something that's happening psychologically. So really connecting the dots there and supporting our team. So those are just some of my thoughts and things we're processing from the target side.
Great, thank you very much, Carly. James from the ERISA Industry Committee, your perspective as another key policy holder and director on the Capitol Hill.
Sure. So again, I think that Jim nailed it and hit the points that needed to be hit. I think there's a couple things that I would probably add. I mean, first and foremost is a lame duck session is always a bad bet in terms of expecting results to come, because sometimes they don't even happen. And usually when they do happen, whatever they do, it's just disappointing, right? Whatever it is that you hope they're going to do, that's not what they do. That being said, because the government is going to be funded through December 11th, that will necessitate a lame duck session. So we at least do have some insight into the fact that somebody from Congress will be here in DC on December 12th, or else the government will shut down, which purportedly nobody wants, right? So we can expect there to be some activity here, but what it's going to be, you know, I agree with Jim. I wouldn't expect it to be super substantive, and I wouldn't expect it to yield probably the kind of results that we're hoping for in terms of a larger COVID relief package, including provisions to be helpful with on-site clinics and helping to reduce some of the burdens that are on individuals enrolled in high deductible health plans. Now, I will say this, if Joe Biden is going to be the next president, it's a pretty safe bet that Democrats will control both the United States House and the United States Senate, because whoever wins is going to have some degree of coattails, right? And only a very small number of seats need to flip. I think it's a safe bet to say that Martha McSally's probably not coming back to Congress. I think that Susan Collins from Maine also probably not coming back to the United States Senate. So we're looking at the coattails needing to move 1 or 2 seats to change who's in control of the Senate. I'd go further and say, if Joe Biden is the president, and if the Democrats have 50 or 51 votes in the United States Senate, especially if a Supreme Court nominee has been moved through the United States Senate prior to January 1st of next year, it's virtually a lock that the filibuster will be ended in the United States Senate, meaning that legislation will be able to pass with a simple majority and that it can be permanent, right? Unlike some of the temporary measures like the Tax Cuts and Jobs Act that expires after a certain amount of time. And with the elimination of that filibuster, I'd go further and say it's virtually guaranteed that there will be an expanded government involvement in the healthcare system. Now, what's that going to look like is anybody's guess. Certainly, it could look like a government-run so-called public option that could be offered to individuals to purchase through healthcare.gov or through state health insurance exchanges. It could look like an expansion of the Medicare program, right? Where today you need to be 65 to enroll. Well, they may make that age 60 or 55. I've even heard that they're considering the age to be 50. And there's a lot of reasons to believe why they would want to do that, because not only would adding 50-year-olds to Medicare potentially reduce costs for employers, who then would only be insuring a younger population, but it would actually extend the life of the Medicare Trust Fund. Because while we think of 50 to 65-year-olds as older folks who have more chronic conditions, in terms of the Medicare population, they're whippersnappers, right? They're younger, they're healthier, and they're going to be less costly. So if you put those people into Medicare and have them pay the average cost of a Medicare's enrollee's annual cost, that actually makes Medicare more financially sound than it is today. So again, crystal balling from me, that's a lock, something that's definitely going to happen. Now, if President Trump does come back to Washington in January, and he'll probably still have the Senate, but it's very hard for me to imagine that you get enough House seats flipping for the House to go Republican. I think in an era of divided government, the president is going to lean more on what can be done with executive authority outside of having to move legislation through Congress. And we've already seen an interest in using executive authority to enhance benefits for individuals enrolled in high deductible health plans, right? It's happened several times during President Trump's tenure. And so I could imagine a situation which with proper cajoling and a good campaign behind it, the president may look at, for instance, unilaterally moving to change fair market value requirements for those individuals in order to enhance the care that they're able to see. And I think that even today, you're going to see some major executive orders roll out, and the president's going to preview some of the things that he'd do if he has control enough to make serious changes to the healthcare system. So with that, I'll stop and hand it back to Larry.
Great, thank you. Thank you all for your comments. Very much appreciated. And for the audience, I do want to pick up on some of the last things that James mentioned. The National Association of Worksites Health Centers has been working with Eric and ABC and Premise Health and a number of other organizations in the industry and employers to address the issue of the requirement that says that an individual who has an HSA must pay some fair market value fee in order to use a clinic services or staff there, even if the employer charges nothing at all for anyone else. This requirement originally came, as Jim said, back in 2008 from an IRS and actually a COBRA definition of what an on-site clinic was, which was just an entity that offers first aid and triage. So someone in an HSA can get those services at no cost, but anything beyond that, there has to be a fee. And what we've seen is that employers have been somewhat reluctant to get into the area of worksite centers because they feel there won't be a lot of utilization if they have a large HSA population. And for those employees and dependents with HSAs, particularly those with low income, they see that the center would have some out-of-pocket costs for them and could be reluctant on that. So we're working with a number of partners to try to change the law, change the definition so that HSA eligible people will not lose their eligibility to contribute to their HSAs if an employer does not charge. We'd like to remove that fair market value requirement. We'd like to increase the definition of on-site clinics to mean any type of health center, whether it's on-site, near-site, virtual, or mobile, and that it can offer the full scope of services. So we're working for that. In fact, all the members of NAWHC and our vendor partners will be invited to sign a letter to encourage Congress to make a change in that. James, could you talk a little bit about that for us?
Sure. So, and Jim talked about this too in the HEALS Act, which was a piece of legislation that the Senate had initially introduced to sort of work towards a compromise with the Democrat-controlled House. There was a provision included that I think pretty significantly expanded the amount of services that could be offered free of charge, or at least at a reduced rate below market value, to individuals in a high deductible health plan prior to the individual hitting their deductible. And having that included in the base proposal coming out of the GOP Senate is a very positive development, because it shows that there's a lot of support at the very highest levels in the United States Senate to improve care for beneficiaries as it pertains to worksite health clinics. But, you know, as Jim mentioned, that bill was scuttled, right? Because there wasn't an agreement just within the Republicans, just within the United States Senate about spending $1 trillion, right? And so they came back with this other bill that was half as big. It was only $500 billion. And many of the provisions that we cared about, including that provision on on-site clinics, they fell out and they weren't contained in the bill. And so we're working with Larry and with the new group of interested stakeholders to try to urge Congress, like, put that back in, right? When you're going to do your next piece of legislation, especially one that touches the tax code, which governs HSAs and the rules therein, when you're going to do one that has to do with COVID, we need that provision because there's millions of people who could benefit from it. And so we're asking individual companies as well as trade associations to sign on to that letter.
Great, thank you. Stu, could you comment about the impact of the fair market value requirement on your vendor partners and what you see for your employers?
Yeah, happy to, Larry. And let me say, nothing I'm going to say is necessarily representative of our client base. Let me give that kind of qualifier. Employers are incredibly frustrated by this restriction. To say it's absurd or irrational, well, it's legislation. So, that happens sometimes. But we have found that employers, and again, not necessarily our book of business, are ignoring or significantly discounting the adherence and compliance with this because it is a serious obstacle to care for people. When you think about meat processing or poultry, some of the lower paying industries, a fair market visit to the health center that comes out to $37 or $50, that's untenable for these families. And they're the ones that need this care the most in many cases. So it makes no sense to employers that we're creating these unnecessary obstacles. We've seen a whole range of solutions. We've seen a fixed fee that the company says is justifiable and defensible as fair market value. We see other employers saying, there's a menu here and this is what it's going to cost coming out of your HSA if you visit the on-site or near-site health center. I'm not aware of any enforcement by the government on lack of compliance with this, which further emboldens some employers to say this is ridiculous. We're gonna do it our way. Is it an obstacle to this industry growing? Probably. I mean, it can't help. But I don't hear the Aons, the Mercers, the Willis Towers Watsons really pointing to that as something where the floodgates would be opened if it were removed. It needs to be removed because it's absurd and it is preventing people from getting care. It needs to be removed because it would improve attribution and utilization. And everybody in this industry knows the more utilization we have, the more value we create for the patient and for the employer. And so, again, can't predict where it's going to go. Employers are going to do what is in their best interest and what they think is the right approach. And I think you're going to continue to see this full spectrum of trying to solve for this until Congress does so.
Thank you. Again, I would encourage the attendees who are watching and listening in to submit questions. We've got about another 10 minutes left. Carly, let me ask you, with the COVID-19 situation, as you've mentioned, and all the other things going, what do you see as the future of health centers sponsored by employers? What do you think they're going to look like, either for Target or for your colleagues? And where do you think the focus will be in the future?
Yeah, I mean, I think all of this has proven a really strong case for our worksite health centers in particular. It's been really, I think, positive for us to see that throughout COVID, when the majority of our headquarters team members are working from home, they are still reaching out to our on-site clinic for their healthcare needs. So early on in the pandemic, that was through virtual visits, but now we're seeing that shift back where our team members are actually coming down to our on-site clinic for their healthcare needs, even though they might not be physically in the building every day. So I think just showing that strong value of that relationship that our team does have with our providers and that they are trusted providers. Our healthcare team at our on-site clinics, we partner strongly with them for our vaccination strategy. So flu vaccination strategy this year, and then I think looking at what that COVID vaccine strategy will be moving forward is going to be key for us. And I think really that value of having that trusted healthcare provider to make sure that we're getting quality care for our team members is huge, and making sure that we are helping to drive the initiatives that we want to drive, whether that be around weight management or mental health, that we're aligned. And what we're saying from Target is also what our team is hearing when they go see their providers at our on-site healthcare system.
Great. Thank you. Stu, do you have a perspective on how your industry or your particular centers will change in the future?
Well, virtual is here in a much bigger way for good. So, you know, where does that level out? We hit about 83% of all of our visits back in the spring were virtual, most of them video. Now we're back to baseline utilization, but it's more of a 50-50 mix. And I think what Carly described is dead on. Hopefully her experience is the experience that employers had, you know, universally, because that was the right way to solve for it, certainly. But yeah, we're going to see more digital, whether that's the use of peripherals. I mean, I don't know if the Apple Watch's Pulse Ox is any good or not, but the point is that there are peripheral technologies that are going to accelerate and broaden the use of virtual platforms. So virtual is here in a very different way, and it's here for good. I think that our industry has to find a way to make itself more valuable than just delivering primary care or occupational health. Those are the tall poles in the tent for our industry. But I can tell you behavioral health is the highest demanded add-on service right now here at Premise. Can't hire enough LCSWs or clinical psychologists. That's not going away for all the reasons we know. And I think the use of data, so digital engagement and the use of data, our industry is either going to figure out how to leverage those two areas to the benefit of the patient and the employer, meaning how do we improve health and reduce cost through engagement and data, or we will suffer the consequences because there will be disruptors that come into the industry that solve that for us. That's my 2 cents.
Great, thank you.
Hey, Larry, could I just add a quick comment to the important point that Carly was making relative to testing? You know, obviously, a big part of the whole return to the workplace effort is going to depend upon testing, either because it's going to be something that's required or just as a practical matter, something that employers are going to feel that they need to do. And so clearly on-site and near-site clinics, you know, can play playing an amazingly valuable role in that whole effort. But it also raises the point, I think, that employers are being, you know, asked to essentially fulfill a public health function, something that under normal circumstances, if you can call any of this normal, you know, would be performed by some governmental entity. And so a question obviously has arisen, sort of who's going to pay for that? And the HEROES Act that I mentioned at the outset of my remarks, that is the House of Representatives passed pandemic relief bill, does provide in it $75 billion for covering the cost of testing as well as contact tracing. So I just wanted to work that point in there.
Well, that's interesting. Now, tomorrow at our forum, we're going to have representatives from the CDC talk about their recommendations on contact tracing, screening, and vaccine distribution. And in fact, they've reached out to NAWHC to talk about how worksite centers can participate in vaccine distribution. So clearly, if there is something in legislation that would help employers get reimbursed for those as well, that would be great. So in the final couple of minutes, Jim and James, Biden has said the day he gets in, he would require a national mandate on masks. Is that a legislative thing or is that an executive order? And how would that be implemented?
I mean, I would start with the word, it'll be messy, right? Because you can make a proclamation at the federal level, and that doesn't mean that there's going to be necessarily enforcement. And I can guarantee you that somebody, somewhere, they'll find somebody who will sue, right? And then it'll be tied up in the courts. But I think, you know, what President Biden has, or sorry, what a President Biden would try to do to contrast with previous leadership, I think, would be to try to demonstrate more of an interest in there being sort of one centralized hub of decision making that filters down to the states and to the cities and to the localities and to the employers, et cetera, as opposed to what we have now, which is there is like sort of a confab that happens on the federal level But then they kind of delegate to the states and they say, okay, well, here's maybe some recommendations. Here's maybe some ideas. Here's some best practices. Now, like, go figure it out, right? And then you have vast variation in what South Dakota decides to do versus what Pennsylvania decides to do. And they want to kind of eliminate a lot of that variation. And so I definitely think there could be a mandate that could come from the very top that they would expect compliance with. But whether or not there's a legal framework for that, I think is an open question. I don't know what Jim thinks about that.
I would just associate my views entirely with what James just articulated very eloquently. I think that hits the nail on the head.
Great. Well, again, on behalf of our organization, I want to thank all the panelists, Jim Klein, Stu Clark, Carly Deer, and James Gelfand for your participation. I now would encourage people to go back into the lobby. We're going to have a 15-minute break for the exhibits. I'm sorry, a 10-minute break. We're going to reconvene at the hour, which would be 12 noon Eastern time. At that time, we're going to have our next session regarding measurement of financial outcomes. So please enjoy your break. If you're home, go to the refrigerator, pick up some coffee, walk the dog, whatever you might need to do. But please do visit the exhibits. Remember, there's door prizes there for you as well. And we'll see you back at 12 o'clock Eastern time. Thank you very much, everyone. Bye-bye. Thank you all.